Good afternoon, everyone, and good day, depending from which time zone you are. Welcome to this HIV prevention choice in an era of new technologies in terms of balancing innovation and community-led prevention. Welcome. I can see we are now around 53 participants. And once again, I want us to welcome all of us. This webinar has been agreed together with our colleagues from SSLN, IMARAA, African Sex Work Alliance, African Network of People Who Use Drugs, GATES, and the KP Transnational Consortium. That we will be having these webinars. And today we are really in the moment where HIV is shifting, new biomedical tools are open, but community-led, right-based approaches must remain central. Why are we having this webinar in this moment? It's because as the key population, we are still facing the highest burden. We need prevention choices, not prevention replacement. Your mandate today is just to move from knowledge to advocacy, leave tools to influence donors and our governments. Just to say, from the perspective of the African Network of People Who Use Drugs and the harm reduction champions and the key population, African Sex Work Alliance, GATES, IMARAA, and KP Transnational Consortium, together with SSLN and our stakeholders from different parties, we really welcome you to this. And today we have very great speakers. May I also allow them, they will be introducing themselves once they are doing their presentation. And at this moment, allow me to call Clarice Pinto from the WHO to kick us off. Clarice, you got the floor.
Thank you so much, Ahmed, and good afternoon and good evening, good morning to everyone wherever you're dialing from. It's a pleasure to be here with you all and to share a little bit, very briefly, the WHO guidance on services for key populations, focusing on HIV prevention in the context of new technologies and how we balance innovation with community-led approaches. It's quite important for us to be here with you because, in a sense, it's a fight that continues to be very relevant for us. Just a reminder about what we are looking at when we talk about key populations, and to start with an important reminder that key populations do not exist in isolation. People often face multiple overlapping vulnerabilities and their needs are interconnected. So our response cannot be siloed. We need approaches that are integrated and flexible and that reflect people's real needs and values. And at the center of the WHO guidance is combination prevention. This simply means that we begin to look at three things: human rights, scientific evidence, and community perspectives. It also means combining different types of interventions and not relying on just one. Right now, we are seeing exciting new prevention technologies, for example, long-acting injectable PrEP like lenacapavir, digital and online interventions, and new self-care options. These are very relevant because they can expand access and give people more choice, but they do not replace what already works. We still need strong community outreach, peer support, and action to address stigma, discrimination, and legal barriers. So the key message here is innovation is important, but it also needs to be combined and with proven community-led approaches. So the WHO guidelines bring together recommendations across HIV, viral hepatitis, STIs for all key population groups and across the continuum of care. So when we talk about prevention, let's not forget about the need for people who are living with HIV to continue to take their treatment and to become suppressed. This way, we can zero transmissions. Um, these guidelines also very clear that people still face barriers like stigma, discrimination, criminalization, and poverty. So prevention is not only about new tools and technologies, it is also about removing these barriers. That is why WHO strongly recommends rights-based, community-led, and differentiated approaches for service delivery. You will see that across the WHO recommendations, you will find peer navigators, virtual online services, behavior interventions, and CAMSETs. But also, you will find that as a central part of this is community empowerment. This means that key populations are not just receiving services, but actively shaping them. Community-led programs and peer approaches help build trust, improve access, and make services more relevant. So in simple terms, when communities are involved and leading, services can work better. And we have a lot of proof and evidence on that. It's just about how to make use of this evidence for changing the barriers that we find today in the field. The WHO guidance places community-led and peer-led services right at the center of the HIV response, and it also looks at how we have to focus on working with healthcare providers to improve the quality of the services provided and remove stigma and discrimination, but also engage communities in putting together what are the key interventions that are best placed to ensure that once these services are integrated, they can function well and make sure that communities actually feel like they can access them. WHO has many activities related to community engagement, looking at key and vulnerable populations that you can see. It goes across task sharing to lay providers and peer supporters, psychosocial support, peer-led adherence support, community-led models, tracing and re-engagement in integrated services. These are going to be here available for everyone that accesses these slides, but it's quite important to think that all these recommendations apply directly to key populations as well. You will see here that there are specific policy briefs and publications where practical guidance is given in looking into action and design of programs that really respond to people's needs. And just a reminder that in 2022, WHO also published a group of interventions into 4 categories. So enabling health and broader health and supportive interventions that are looking at the important synchrony of comprehensive care. They should be taken as essential services that will be adapted by context according to the availability of funds, availability of human resources, context priorities. But it's very important to consider this when decisions are made for PP programming. I put in very down in the slide, and when you receive this slide deck, you will have access to the full checklist. But there's a checklist that we included here just to remind us that each key population might have needs, specific needs, and we have to reflect on that as well when we are talking about the package of services. And in 2025, when we went through the whole, process of priority setting with the abrupt funding cuts, we saw a need to exercise prioritizing in a stepwise approach. And we had an indicative exercise that looks at how we could do the step-by-step in a structured, transparent, and engaging way. This exercise looked at different levels of the cascade with a very merged and representative group experts to look at how we could go about prioritizing services into 3 tiers. When you get into this priority setting exercise document, you will see that it was very difficult to get to the 3rd tier, because normally we want to keep everything and we want to do everything, but it's not possible. So one way of thinking is that when we need to make decisions, the hard decisions in the field, we need to consider specific needs of specific populations to be specific enough in terms of whether a service has started already, has been given already or not to this specific group, to focus on continuing services or starting services. So these are the bits and pieces that we need to consider when we go through this process. You will find that there's a whole table with the key points for key population priority setting and how we need to engage populations. So finally, just to bring all of this together, and let me close with a few key messages. First, services need to be centered and to the needs, realities, and preferences of key populations. Second, that we need a comprehensive package that is integrated and across the cascade, but also enabling interventions. Third, that addressing stigma and discrimination is key to reach people and let them have access to care. Fourth, that it's very important that community-led and peer-driven approaches are not an add-on, but complementing the services, and they are central to the response. And finally, let's make sure that we engage with all the levels of implementation when we are discussing programming. Thank you very much, and this is all from my side.
Yeah, thank you so much, Clarice, and for that very comprehensive remarks. We will be following up, and once again, let me welcome all participants and the panelists that are here, those who have confirmed. And in the next session, I'm going to now invite Khaled Pretonius, and then thereafter Clemens will follow, and then Anil in that manner. And please just make sure you keep time so that your fellow panelists also can get an opportunity to present in good time without pressure. Thank you, and over.
Hi, hi there, and good afternoon to everyone, and thank you for the opportunity to share some of our work with you around prevention planning and modeling. I'm going to share my presentation directly, so give me a moment to load that. Let's see. I think I will need to get sharing permission for that. Okay, can I replace the current share? Let's try that. Yeah. Okay. Is this showing for you?
Not yet.
Not yet. Okay. Let's see. How about now? Is that showing? Should.
It's coming, but you have to put it in presentation.
Yeah, we can
Better?
Yeah, that's fine. Yeah.
Okay, great. So my name is Carl Pretorius. I am with Avenir Health, working with John Stover and Rob Glavius. Many of you would know them from work in the HIV area, estimates and impact analysis. I've been working with them for probably 15 years now on the use of HIV models in prevention planning and strategic planning for HIV programs. So in this presentation, I want to share a few ideas with you and some of the work we've been doing in the last year and let's say year and a few months since the abrupt funding cuts in the beginning of last year. We've been working with several countries on understanding the potential implication of these funding cuts and how they may proceed going forward, as many of them are preparing new strategic plans and trying to mobilize new resources. So just an overview, we did one project around the importance of condom use programs, and I will share some highlights out of that analysis from you. This analysis was across 13 countries, looking at what would happen if there is different levels of condom use programs cuts in the countries, how that will affect actual condom use and how that will affect the epidemic. We also work with, I'm going to get myself a pointer here. We also worked with several countries in collaboration with UNAIDS and funded by the Gates Foundation to prepare several types of prevention analysis. We started after the funding cuts and before the MOUs were shared. And now, since the MOUs are shared and there's a bit more clarity on what the eventual funding envelopes will be, we are now doing similar analysis, trying to understand which interventions to prioritize. I will talk a bit about that work. And I want to say that we provide ongoing support for a portfolio of countries, many of which you represent here today on the call. And in this project that we are funding for, we are providing support around cost effectiveness analysis and what we call strategic modeling, where we package these results, into decision-making tools, into resource needs mobilization tools, and so on. The method that we use centers around the goals model, which has been used for many years now and has been applied widely in countries that are typically Global Fund eligible countries and other countries looking at strategic analysis. The primary use of the model is to look at new infections and how it's distributed between different population groups and particularly key population groups that is important here today. We've analyzed the historical impact of programs like we did now for condom use, which I'll show shortly. We look at the financial cost and implications of achieving future coverage targets. So we will talk a bit later in the session around other speakers around UNAIDS targets for programs for key populations. So we work with the projection of the cost of those. And then we look at the cost effectiveness of several interventions. Here I'm going to just give this highlight of this analysis we did around condom use analysis, condom use. So we looked at 13 high-burden countries in sub-Saharan Africa and asked the question, what would happen if there is a decline in condom use of either 15 or 30% that would result from the funding cuts and basically a decline in condom supply to populations, including key populations. And we projected that new infections would increase across all these countries between 22 and 28%. I'll go into the average result just now, but the highlight here is that condom use showed up in this analysis as the most cost-effective option, among interventions for key populations, and in most cases, it is also a cost-saving program. This was the key result where we showed how what would be the increase in new infections aggregated over these 13 countries if there's a 30% decline or a 15% decline. And these were built on top of constant ART or maintaining ART coverage. So it shows that there will be, it is projected that there will be a significant detrimental impact if there's any reduction in condom use resulting from reduction in condom supply and condom programs. I will just proceed quickly in the interest of time. We are also currently working, as I mentioned before the MOU, it's sort of the era last year, before MOUs were available, we worked already with UNAIDS with several countries closely, trying to understand the implication for funding cuts and different funding potential projections for their epidemic context. In this analysis, we have to agree on counterfactuals, whether we maintain ART coverage or not. In most of the analysis we do, we look at a time horizon out to 2050, and we use a cost effectiveness indicator called a disability adjusted life year to do this work. We work closely with UNAIDS within their resource needs modeling framework to obtain unit costs for this work. but I will shortly mention how important country-specific work is. In a typical analysis among these countries, the results come out like this, where on the left-hand side we have axis, we have cost per infection averted. On the y-axis, on the x-axis, we order the interventions in increasing or basically decreasing cost effectiveness. So the most cost effective intervention is condom use, and it's actually cost saving. It's got a negative cost per daily averted value. And there are some key population programs that also for this country show up to be cost saving. And these interventions on this side, they are not cost saving, and they can be assessed whether they are cost effective against criteria, or whether improved targeting or other other ways of delivering the service might make them cost effective. But this is just the basic strategic analysis that we can do for countries to try and understand which interventions they might prioritize or not. Basically, the takeaway message here is that these interventions are cost saving and should, if you're considering cost effectiveness alone, should be scaled up first, and then these ones should be considered and may require strategies to make them more cost effective or to make them more sustainable. This result is just a summary of this type of analysis over many countries. Here we have 15 countries, and here we're aggregating the results and showing them as well, the country variations. So again, generally, condom provision is cost effective, followed by some interventions for key populations, including, in some cases, PrEP, and so on. But the point I want to make is the huge variation between countries and the need to do detailed country-specific work, and that requires a lot of country engagement to get reliable results out of an analysis like this. So in brief, our condom use analysis, condom program analysis has shown up consistently across these countries that it's a cost-saving intervention. Sustained condom supply and promotion will be essential to achieving and then maintaining epidemic control. In the strategic modeling that we did around funding cuts and funding projections, there's several components to the analysis. We look at trends relative to a counterfactual, so the country must understand, what will they provide and what will be maintained at baseline levels, and we measure impact relative to that. Or we can construct several types of counterfactuals. We look at the impact towards targets as these interventions are scaled up towards global targets. More about that will be said shortly. We suggest which programs might be the most important to implement. I should rather say that they are the most cost effective to implement. The importance of programs has more considerations, and I'm sure much will be said about that today. We help countries to focus their efforts to improve existing programs and also to advocate for additional resources, like in the case of condom promotion programs, that these programs should not be left behind. Just a few more remarks. The analysis around key populations is particularly sensitive to data that we are quite uncertain about. So it requires estimates of HIV incidence. Those are often quite noisy data. There's uncertainty around efficacy and cost depending on who implements the program. So all of that has to be discussed and modeled with countries. And the current baseline service coverage is quite difficult to estimate in most cases. So this makes it very important for a detailed country engagement process. But as a closing remark, I can just say that the planning of prevention programs for key populations should not be based just on cost effectiveness analysis alone. It is a very important tool, and it does help to guide overall strategy. But there are many considerations within that, including considerations of equity and the sustainability of programs and also community engagement. Our models require a lot of data to model the implications of different modalities here. So that all needs to be discussed in detail with countries when we try to refine this model to their context. But just like for the condom use program, we can show that prevention programs for key populations are critical to achieving and then maintaining epidemic control. So I will leave that here. We are busy engaging with a number of countries, collaborating closely with UNAIDS, and we have the capacity to do further analysis and technical support depending on consultations. And I want to thank you again for the opportunity to share some of our work with you today. Thank you.
All right, thank you. The next speaker would be Hita Marie, who will stand in for Clemens. So please have the floor, and please let us also know that the timer is still working. Yeah, so view your clock. Yeah.
Thank you very much. So good morning, good afternoon, everybody. As Ahmed said, my name is Heather Marie Schmidt, and it is my pleasure to be here on behalf of UNAIDS and the Global HIV Prevention Coalition Secretariat to talk about the considerations for key populations in the HIV 2030 Prevention Access Framework. Next slide, please. Within the Global AIDS Strategy, we have clear and ambitious targets for prevention, and this includes 90% of people in need of prevention using effective HIV prevention options. These targets are translated into second-level targets, which are quite important for us in this room virtually, because they are also broken down by population and program-specific targets. Ultimately, we are aiming to have a massive impact, and that is to reduce new HIV infections by 90% in 2030 compared to 2010. Next slide, please. And so translating this into estimated numbers to get an idea of what the scale of this means, we are looking at 20 million people on PrEP, 20 billion condoms, 38 million people from key populations reached with combination prevention, including 7 million with harm reduction, and more than 20% of domestic HIV funding going to HIV prevention. Next slide. So in this current context, and with such ambitious targets, we have to do things differently and support and accelerate country-led responses to be more sustainable, prioritized, efficient, and yes, integrated. So this is where the 2030 Prevention Access Framework comes in. So it focuses on that top line target that I mentioned that covers primary prevention, which is 90% of people in need of HIV prevention using effective prevention options by 2030. And it presents milestones and actions for achieving those targets, and with specific considerations and mention around key populations as an example. Next slide, please. It should go very much without saying that people and their communities need to continue to be at the center of the HIV response and HIV prevention response, and that supporting empowerment of key population communities needs to be explicit, not just behind the scenes. The framework is person-centered and structured around people's prevention journeys and reflects the need to understand prevention needs, options and benefits, access prevention services, use prevention options effectively, and experience an enabling environment, and that this needs to be supported with a multi-sectoral response. It cannot just be HIV or health alone. Next slide. So digging a little bit deeper into this, addressing the key factors that shape and empower people to make decisions about HIV prevention through people-centered design and communications is really crucial. There is such an opportunity now and an imperative to apply person-centered design to create a consolidated but differentiated approach to communication planning, and that accounts for the differing and specific needs for people such as key populations, and also that accounts for subpopulations. Key populations, they're is not a monolith, and it's really important that there is this segmentation of those differing needs. So this is all included in the framework, and the guide shown here on the left provides some more specific guidance and evidence-based suggestions for prioritizing approaches, noting that digital media and mass marketing are relevant for key populations, and that virtual and interpersonal outreach and counseling approaches in particular are going to be highly relevant. Next slide. So key population-specific services have been reduced in many countries as funds were reduced and integration proceeds. However, the evidence is really clear that differentiated approaches and models are effective and needed for key populations in most settings, and that collaboration between key populations and service implementers is essential. The optimal mix of platforms will depend on a variety of factors: epidemiology, unique needs and preferences of subgroups, trust and accessibility of mainstream services, legal context, stigma, discrimination, and many other factors. Different resource scenarios and contexts will lead to different program designs, with additional service delivery options considered in contexts where more resources are available and environments where dedicated services are necessary. Where tough budget decisions will need to be made, collectively, program managers and community organizations need to identify and should identify collectively population-specific approaches that are priorities for preservation. For instance, where other types of providers are just not sufficiently capable or trusted by key population. The framework provides tools that can help with this, and additional guidance is shown here on the left and middle that contextualizes this, including soon-to-be released best practice guidance for key populations. Next slide, please. And I just want to very, very quickly highlight in particular that it is important that we don't forget about virtual interventions and self-care approaches, as they can be incredibly impactful, particularly for key populations and many settings, for many reasons, but also because of the increased and additional level of confidentiality. Next slide. Offering a structured choice of HIV prevention options can increase coverage and be cost-effective. Clarice has already spoken a little bit about this. So all I want to emphasize here is that different options work for different people at different points in their life, often with different partners. It is not a one-size-fits-all approach. So, for example, PrEP can and should be a priority for key population service delivery, but may be complementary for others. Harm reduction has to remain a top priority for people who inject drugs. Condoms as a multi-purpose technology remain an important option for everybody. So planning should take into consideration the needs of various populations and subpopulations for those prevention options, and the framework outlines how. Next slide, please. On structural interventions and societal enablers, I won't go too much into this, except to say that there is no scenario in which investment in human rights, addressing stigma and discrimination, and key population engagement are not required. And so there is guidance that is outlined within the framework. And it is also important that there is strong government commitment and stewardship for a coordinated national response, involving all of the key stakeholders. Next slide. So prevention is complex. There are many interventions, populations, platforms to consider. And if we cannot do everything everywhere all at once, how do we prioritize? Next slide. So the other key to the framework is the 5 Ps of prioritization, an approach to enhance prioritization in a resource-constrained environment. So the people are again at the center. There must be a focus on key and priority populations who would benefit the most from prevention. People-centered precision in prevention means using data to design programs so that the right people can access the most suitable prevention options. Focusing on prevention options or efforts on key populations and their partners remains a highly effective way to reduce population-level transmission, and this includes in generalized epidemics. In terms of place, identifying the places for the most impact, a precision focus on locations does not always mean picking a few areas and only focusing on them. It can also be a call for adjusting the intensity of actions in all the relevant places to fit the levels of HIV incidence and the need. In terms of platforms, I've spoken quite a lot about this, but it's delivering information and services in the best way, and the packages that best mix of interventions. And finally, price, maximizing the value for money and sustainability. We know that this is underlying all of the conversations right now. It is essential that adequate domestic funding is provided to ensure key populations have access to HIV prevention. And for example, in 2024, only 2.6% of total HIV funding was spent on key population programming, even though key populations accounted for 69% of new HIV infections outside sub-Saharan Africa and 26% in sub-Saharan Africa that year. The 2030 Prevention Access Framework provides further tools and guidance on this concept. And so this is my final slide. Next slide, please. The framework, in essence, is a call to action for country-led HIV prevention. By 2030, every person at risk of HIV should have access to a prevention option that suits their needs. But this is only possible with a transformed HIV prevention response that centers people and communities and a concise, community-informed, collaborative plan of action. So thank you, and thank you to SSLN for organising this webinar, and also to all of you for your tireless work in driving forward the response.
Thank you so much, Marie. Yeah, next, let's listen to our very own Anil. You got the flow.
Thanks so much, Ahmed. My name is Anil Padavartan. I'm the health lead with GATE, Global Action for Trans Equality, and I'm based in South Africa. And I'm going to be looking at what is a balanced approach to HIV prevention for key populations. Next slide, please. So we're just to take a step back and look at where we are in this changing global context and what is actually at stake. We've got reduced donor funding, and that has resulted in strategic shifts. And that's very clear that we need to acknowledge that it's the reduction in funding that's driving the shifts, not a change in the science or a change in the epidemics. So this creates opportunities, but it also creates a lot of risks for community-led responses. Some of the risks that we're talking about today is, first of all, the risk of HIV prevention as a whole being deprioritized. And there's often a lot of talk around the fact of you need to prioritize essential life-saving services, which is often defined as treatment, with prevention being comprehensively sidelined. And this is particularly true of prevention services for key populations. The other risk that we've got at the moment is the potential risk of the overshadowing of the prevention response by LEN. LEN is very, very exciting. However, it should not be, because LEN is very sexy at the moment, it should not therefore be that the rest of the prevention packages are deprioritized. And also we need to make sure that we're not having a very medicalized focus on LEN and ignoring the fact that you need community systems to ensure an effective rollout. So what I'm going to be talking about today in my presentation, as you've all heard in this webinar and you'll continue to hear, there are a lot of resources out there. There's a lot of information resources. I'm going to be referring to two, and I'm going to be putting the links to them in the chat afterwards. First is the Joint Communities Guide to Global Fund Grant Cycle 8. It was developed by GATE in partnership with Impact, INPUD, NSWP, and Y+ Global. It specifically talks about the Global Fund Grant Cycle 8, but really it provides information that would be helpful for whatever advocacy you're doing for HIV prevention for key populations. And then also a really exciting new resource, which is the South-South Learning Network's peer-led approaches for HIV prevention for key populations, which was developed in collaboration with key population networks. And it brings together all of the scientific data and the evidence for why we need peer-led, community-led responses in HIV prevention. Next slide, please. When we're talking about maintaining access to prevention services for key populations, we need to know, as advocates and activists, when we are going into advocacy spaces and advocating for community priorities, because there's less funding and therefore it's a more acrimonious situation in country. There's a lot of conflict over scarce resources. It's first of all really important to go in armed with data. And the other thing is it's really important for us to remember solidarity and standing together as key populations, because our voices are more powerful collectively than if we are each speaking alone. In terms of data, I'll give an example. For example, UNAIDS data shows that at a time when the global incidence for HIV is decreasing, HIV incidence amongst trans women and men who have sex with men is actually increasing. And that's really important data to be putting on the table, because when we're talking, as previous speakers have just said, when we're talking about prevention services, it's not just a question of how much they will cost, but how much it will cost not to do particular interventions. So if we have got an HIV response that is focused on treatment, and it's focused on treating increasing numbers of people living with HIV, rather than on providing effective prevention and on dealing with the underlying drivers of the HIV response, the human rights issues that need to be addressed, then that is by definition not a sustainable response. And it does not matter whether the funding for it is coming from donors or coming from domestic funding, unless you're dealing with the HIV epidemic as a whole as in a sustainable way that addresses the underlying factors, it is by definition not sustainable. So what does the research tell us? It tells us that we need tailored services focused on specific communities. We need choice in order to improve uptake. And there's also a lot of data showing that community-led services are not only very effective in reaching marginalized communities, but they can also be more cost-effective than facility-based care. Next slide, please. So, as previous speakers have said, we really need to be placing people at the center. And what this means is not just continually repeating the words people at the center and people-centered response. It means that the people who are the recipients and the beneficiary of the services need to have a voice. We need to have community-led organizations in the room being part of decision-making processes, and we need to go in providing our community priorities, and community priorities need to be seen as a source of data and an important consideration when doing your programming. I'm not going to go into a lot of detail on these slides because they are from the Joint Communities Guide, and you're going to all be able to read all about it afterwards, accessing it via the links. But just to look at the trans and gender diverse community. Peer-led services are really important for the trans community, given the high levels of stigma and discrimination that trans and gender diverse people experience in healthcare facilities, and given the very, very high levels of violence, particularly gender-based violence and sexual violence that the trans and gender diverse community experience. Crisis support and responses to gender-based violence that are accessible for our community is really key to a prevention response. Next slide, please. For gay, bisexual, and men who have sex with men community, in the context that we're seeing at the moment, where you have increases in homophobia around the world, we have the introduction of really draconian laws criminalizing same-sex conduct, and in some cases criminalizing organizing of LGBTQI organizations, maintaining funding for community-led services is really, really key in order to maintain access. Because realistically, governments that are criminalizing these communities are not going to be socially contracting to these organizations, and maintaining funding from other sources such as donor funding, direct funding, and social entrepreneurship are also going to be key. Next slide, please. For the sex work community, condom programs are a real priority. And I'm not going to go through all, there are many priorities. Some of them are common, some of them are specific. I'm just pulling out this one because it's really important to what we're discussing today. We know that condom programs are not popular in a lot of African countries with a lot of governments. However, these programs are cost saving. They're highly effective and they're community priorities. So providing condoms and lube needs to continue to be a cornerstone of the HIV prevention response. Next slide, please. For people who use drugs, we know that harm reduction and medical treatment, including opioid agonist treatment, are in their own way as game-changing as LEN. And we should be as excited about scaling up these very, very effective responses as we are about LEN, because this is something that is game-changing and has been shown to massively reduce HIV incidence. Next slide, please. And from youth living with and impacted by HIV, the very important point that you need the youth leaders and youth representatives involved in shaping the programs where youth are beneficiaries. And this is something that is common to all key populations. We really need to ensure that the people who are going to be the ultimate beneficiaries of these responses are helping to shape them, because that is the way that they will continue to be effective. Next slide, please. So when you go into the advocacy spaces, make sure that you are armed with data as you go in. And if you're needing more resources, reach out to the various key population networks. We are here to support you. Thank you so much.
Thank you so much, Anil, and thank you for having that presentation, which cover all the key population and of interest, even the young people who are key population. Thank you so much. So now we've heard about the approaches from our previous speakers, and now we are about to hear what are the commitments from the donor. And that today we are very able to have Global Fund, and we are having Maria Felani from Global Fund Geneva, who will do a presentation. And Madonna, you will confirm for me if Regina has managed to join. And at this moment, allow me to give Maria the floor. Maria.
Thank you, Ahmed. And thanks very much for the invitation to join you today. It's great to see so many colleagues online at what I know is a very, very busy time for everyone. We can go to the next slide, please. So I'll focus a bit today on grant cycle 8, and I'll zoom in on HIV prevention and key population programming, with the aim to provide some clarity on some of the guidance related to these areas, with a particular focus on community rights and gender, to hopefully help you navigate the guidance and the tools, and to support some of the conversations that I know many of you are involved in at country level as well as at other levels. So to start with, I'll introduce myself. My name is Maria Phelan. I work for the Global Fund in the Community Rights and Gender Department as a technical advisor on key populations. Great to see so many of you here. So I'll start with the overarching strategic shifts of the Global Fund, and that are guiding everything we do. They feature in the allocation letters countries received, and you've probably heard of these on other Global Fund webinars. And they really reflect how the Global Fund is adapting to the current environment, and there are some changes. And there are 3 shifts that are about the optimization of use of available funds through prioritization, integration, and community systems and sustainable financing. So in relation to prioritization, you'll see a strong focus on this. We've discussed a lot already on this webinar today. Every speaker has touched on it. And what's important is prioritization for what purpose? The aim of prioritization is, of course, to optimize access for most at-risk populations and therefore maximizing our impact in terms of HIV prevention. So that means the availability of services is a prerequisite, but it's also important that those services are equitable, accessible and effective, and reduce barriers to access to services through trusted community platforms. Integration is another discussion that we've heard a lot about already today, and is another strategic shift, and this is about supporting ongoing shifts towards delivering HIV services in a coordinated way within primary healthcare and broader health systems. And integration really needs to be designed to broaden access and prevent barriers to access, particularly for key populations and most at-risk populations. And then community systems financing. This shift is about how the Global Fund will support countries to support integration and sustainable financing of community systems. Next slide, please. So in terms of the GC8 grant guidance, I'm sure you're very familiar with this, but just to highlight that we look at sort of 3 buckets of guidance. The modular framework is the central organizing framework. It outlines eligible interventions, activities, and performance indicators. The prioritization guidance for HIV, TB, and malaria and RSSH component complements the modular framework handbook and is meant to strengthen the decision-making process for countries. These are organized by intervention and outline what to prioritize, what's lower priority, and how to optimize and drive efficiency. For community rights and gender, which I think is a really critical component of the KP programming and has been a theme throughout the previous presentations, you'll find this in 3 places. It's within the disease-specific prioritization guidance, so HIV in this case. It's within RSSH, and also there's enabling impact guidance. And as Anil has already highlighted, and I'll highlight at the end, community partners have developed some very clear practical versions of this guidance. There are podcasts available now, and these are all linked in my final slide with the key resources. Next slide, please. So for HIV, you can go to the next slide. In fact, I'm aware we're a bit short on time. I'll just draw our attention to the program essentials. These are essential programmatic elements of an effective HIV response. These are based on the normative and technical guidance we've already heard about from colleagues at WHO and UNAIDS, and these are expected to be funded to achieve impact across all funding sources, not just Global Fund grants. And as you can see in the context of this conversation, HIV prevention for people most at risk, that includes key populations, also adolescent girls and young women. Those definitions are included in the guidelines and are aligned with UNAIDS, and I'd like to draw your attention to that. In terms of HIV prevention, as you'll see, all of the elements that we've been discussing so far today are considered program essentials. That's condoms and lubricant, PrEP, including long-acting PrEP, harm reduction, voluntary medical male circumcision, and sexually transmitted infections are on the left. I'd also like to draw your attention to the access barriers program essentials, including HIV services integrating interventions to reduce human rights and gender-related barriers, programs to reduce stigma and discrimination, access to justice, community-led mobilization, and a new program essential, which is important in this context, a program essential around reducing intimate partner violence and first-line support and care. Next slide, please. For key populations, I'm building on what Heather Marie has already spoken to you about in terms of the trusted access platform approach or managing key population programs. So really the priorities are around continuing to prioritize delivery where impact is highest. So allocating services based on HIV incidence amongst key populations, as well as available resources. It'll be important to protect the coverage of essential interventions and maintain core key population services. And we could improve this by identifying efficiencies through 3 strategies of optimization, adaptation, or integration. And the Trusted Access Platform document that Heather Marie spoke to has some really excellent guidance in this respect. So I really encourage you to look to that. And we talk about using that Trusted Access Platform approach by combining multiple service delivery models whilst expanding potentially underutilized models. We've talked about online and virtual interventions. KP competent pharmacies and others are other possibilities there. And of course, it's context specific and depends on what's working well in country context already and what can be built upon. Optimizing existing strategies, such as reviewing performance and cost effective of current approaches, is an important component to decide what should be retained, what could be stopped, or what could be expanded or built upon. And where possible, continue to support the integration of programs for key populations into primary healthcare, but of course by identifying any potential risks in advance and implementing appropriate strategies to address them. For example, developing transition schedules and really focusing on KP competency within health units. And again, there's some excellent guidance online by WHO and UNAIDS in terms of that piece. Next slide, please. So I'll move to some of the other areas of community rights and gender. So I'll start with tackling human rights and gender barriers. What's important is there's an emphasis within GC8 on evidence-informed investments. Funding requests should build on assessments of gaps and barriers that have been conducted, often with support from UNAIDS and WHO and other partners. This can include gender assessments, stigma index assessments, barriers. No specific format is required, but it's encouraged that these assessment data points to be integrated into the standard HIV program reviews. As in GC7, HIV-specific interventions to reduce human rights and gender barriers can be funded within HIV grants and from the HIV allocation, but cross-cutting human rights and gender interventions can be included in the RSSH grant and split. And I'll take this moment to note that human rights, gender, and community system strengthening modules are now within the RSSH guidance and modules, and that's where you'll find them within our guidance. Let's go to the next slide, please. So in terms of reducing human rights barriers to HIV, TB, and malaria, the prioritization guidance and the guidance overall follows a very similar framework to those which you've seen in previous grant cycles, anchored within minimum human rights standards and grant agreements and the code of conduct for recipients of Global Fund funding. Therefore, Global Fund investments cannot be used for services that result in discriminatory exclusion or do not respect informed consent or confidentiality. In line with the integration strategic shifts, efforts to reduce human rights barriers should be part and parcel of service packages as a way of making them more accessible and acceptable and improving their quality. And it's important to clearly outline in such integrated budget lines what are the human rights interventions and how are the barriers being addressed. Investments in health products and services are not included here. And the three interventions that you see in terms of program investments under which targeted programmatic interventions to remove barriers for still allow for impactful and evidence-based interventions from the previous cycles to be included. Next slide, please. So in terms of gender equality in GC8, what's new? First, a key change is the use of assessments for all high impact portfolios, helping countries to identify the most important human rights and gender related barriers and using this information to inform the funding request and budgets. The new gender module contains evidence-based prioritized investments focusing on what will most directly improve access, quality and outcomes for women, girls and trans and gender diverse communities. A new HIV program essential I mentioned earlier is the integration of post-violence clinical care into HIV services. All Global Fund supported HIV services should be working towards this, and GC8 brings stronger financing levers through matching funds and technical assistance through larger portfolios. At the same time, we're not starting from scratch. The gender equality marker continues across all funding requests, providing a practical accountability tool to track whether gender is meaningfully addressed. Gender KPI indicators will continue across high impact and core countries, helping to ensure that gender integration is not described in proposals but tracked during the implementation. And a catalytic fund for women and girls remains an important complement to core grants by channeling smaller, flexible resources to women-led organisations. Next slide, please. So in terms of community system strengthening, which I think is another really important component for KP programming, investments in community systems are critical, as we know, and continue in the RSSH modular framework. The key kind of priorities here are organizational leadership capacity building, so prioritizing investments in the capacity of community-led organizations for service delivery, to ensure uptake, adherence, and strengthen linkages, investment in organizational capacities for CLOs for social contracting, for support for registration, accreditation, etc. Supporting safety and security, a very important component for CLOs, is essential for sustainability and continued access. Safety and security can also be programmed for within the HIV modules under community mobilization. Community-led monitoring and advocacy is the other area of prioritization in national health decision-making, not just in global fund processes, and community coordination and engagement. We'll move to the next slide in terms of community engagement, just to highlight the final few points. There do remain minimum expectations for community engagement to be met through the grant cycle, and this means ensuring communities are at the centre of those decisions, priorities and trade-offs. Community engagement remains essential to ensure GCA investments are responsive, equitable and grounded in reality of communities. So early and meaningful consultation is critical, supporting community consultations and other strategies to ensure that communities can input meaningfully into the funding request development process. Resourcing community engagement and accountability. In GC8, a new intervention in the modular framework expands community engagement support to national and sub-national decision-making spaces. And going forward, we need to prioritise strengthening community active participation in health financing, governance and accountability discussions, community influence in grant making and implementation. CCMs, as part of their oversight role, should convene 2 meetings during grant making for PRs or CTs to update CCM on grant design, and CBO, CBLO engagement in involvement in implementation, and community engagement in sustainability, governance and accountability. I'll go to my final couple of slides. Just following on from what Anil had already mentioned, I wanted to also highlight these really fantastic tools which communities have developed, which are about engaging in what I know are very complex processes at the Global Fund. This toolbox has a wide range of different tools that can be helpful across the different processes. If we go to the next slide, please. I'd also like to highlight new tools which will be available soon, some of which Anil had presented, others which are forthcoming. Also the podcasts which have been developed by Seven Alliance, which give further information. And you can email me, I'll put my email in the chat if you wish to access some of these. And the next slide, I think, is the last one. Thank you. So thank you very much for the opportunity to speak with you. Happy to answer questions in the Q&A. Thanks, Ahmed.
Thank you. Thank you so much, Maria, for that comprehensive, and we can see the commitment, and we hope at the country level there will be a clear consensus on the realities of the key population and the community at large. So at this level, allow me to also invite Solomon Wambua, who is the chair of the Key Population Transnational Consortium, to take the floor and facilitate the other session. Welcome. You have the floor, Solomon. Solomon, can you hear us?
Hello, Tony. I hope I am audible. Yes, I hope I am audible. Can you hear me?
Yes, you are. Yes, you are. Please proceed.
Hello.
Yes, we can hear you,
Okay.
Solomon. Yeah.
I don't know whether it's some flag on my end. Okay. Thank you very much, Tony, for the conversations had so far from theme 1 and theme 2, all looking at community engagement in the global fund processes, and of course the larger granting for key populations and the HIV programming in totality. So right now we want to go to a panel, and we will be switching gears to our community members. So by introduction, I am Solomon Wambua, who is the chair of the Key Population Transnational Collaboration. And I also work at the Key Population Consortium in Kenya, and we are also engaged in the GC8 conversations. So I would like to welcome my group of community panelists so that we can get to hear about, the experiences, the lived realities of, and even present experiences of what is going on. So I would like to just start us off with introductions. And from our speakers list, we have Grace Kamau. Are you on the call so that you're able to introduce yourself? Is Grace on the call? Okay. If Grace is not on the call, we can move on to Marineos. Marineos of AVP Forum.
Marineos is on the call.
Yeah, kindly introduce yourself, Marineos. Okay, we are not able to get Marineos. Rita, are you able to introduce yourself?
Hello.
Hello, yes, can you proceed?
Okay. Hi, sorry. I think it's because we were expecting you to introduce us, but it's okay. We can say hi to everyone. My name is Rita Gatonye. Hi, everyone. Thank you for being here. I work with a network of women who use drugs based in Kenya, but working in East Africa, known as the Women in Response to HIV/AIDS and Drug Addiction. I am the director, and we mostly work on advocacy for harm reduction and health. Good to be with you all.
Thank you very much, Rita. And of course, introductions are very necessary. Next we move on to Watara. Watara, are you on the call so that you can introduce yourself?
Yes, Solo, thank you. Good afternoon, everyone, especially from Ghana. And thanks to our presenters. I think this was an insightful information and presentation because currently we are at the writing boot camp for the GC8 in Ghana, and most of what was presented gave me a very beautiful insight to go back to the room and actually push for areas, priorities for our different components. Thank you so much. By way of introduction, I'm Watara Yahya from Ghana. I represent key population on the Ghana CCM, that's the country coordinating mechanism of the Global Fund, and also a member of the executive committee. Thank you and over.
Thank you very much, Watara, for the introduction.
And
we move over to Jay.
Greetings to you all. My name is Jay Mulucha. I'm a trans man living in Uganda. I'm the executive director of Femme Alliance Uganda. And some of the things we do is to advance the health rights and dignity and inclusion of trans and gender diverse persons in Uganda. Thank you so much.
Thank you very much, Jay. And we have Marineos. Yes, Marineos, kindly go ahead.
Thank you. Thank you also for the network. Yeah. I'm sorry. Yeah,
no problem.
My name is Marineus Mutongole. I'm the chairperson of Tanzania Key and Vulnerable Population. Also, we are the member of Transnational Coalition. Thank you.
Thank you very much. And do we have Grace? Okay, if Grace joins, she will also continue. Grace is from the African Sex Workers Alliance. She's the coordinator. So, I can say, in no order, I would like for all the panelists to actually tell us, like, what is the present working environment for KP programming? And I believe we can start with Ghana because we've had a lot from Ghana. Watara, you can actually tell us how is the environment for the key populations programming in Ghana?
Thank you, Solo. I'm sure that this question, I'm sure you are not expecting me to say something very beautiful. The case would have been different if this question was asked about a month ago. But asking this question today means that we know what is currently happening in Ghana. The bill that we were struggling with back and forth has finally been passed by the parliament just a few weeks ago, and conversation around it has started. Even already when there were no bill that criminalized community members, were not making progress in ensuring that members have access to service, members are free, members can be who they want to be and express themselves. And now that we have a bill to further criminalize community members and restrict them further more, I think the atmosphere has not been good since the passage of the bill. One thing that is very critical is that in the bill, when you read it, indicate that criminalization covers all aspects. That means having a KP-led organization, having giving services to KP community members in all aspects. The only exemptions that was made, that was even a last-minute memoranda that was sent joint by the Ghana AIDS Commission together with some community members to the Parliamentary Select Committee and others, the legal team, were able to make an exemption for state institutions like the AIDS Commission, the Human Rights Commissions, to be able to discharge their statutory mandates under the law. So as it stands now, the honest truth is that it's not easy in Ghana, and the community are in fear, looking forward to what is going to happen next, even though we're still having some sort of information that the bill was in a rush and then it was passed without some people, a quorum in parliament. But by and large, we are still waiting to see whether the president is going to assent to the bill for it to finally take the next phase, which is the implementation phase. That is what is waiting currently. But more strategic engagement and ongoing. We know that Global Fund delegations and some other people are engaging with high level to see what can be done in its current state. But I might say that this is highly political. And as we stand now, the Family Value Conference is happening in Ghana, and some of us as community feel that the bill rushed, like the bill was passed because of the conference that is currently happening in Ghana. That's the Family Value Conference that is happening. So the bill was sort of a ground to prepare for that conference to happen. And as it stands now, like I said, we don't know what is going to be like in a month or 2 months to come. But we are determined as community to learn from the experience of colleagues and counterparts from other countries like Uganda and others who have had similar bill in their country. How have they been able to navigate these spaces? How have they able to ensure that community members have access to service? Service is ongoing. How do they navigate such spaces? I think in the next phase as community, that is what we are thinking, preparing for the worst and also ensuring that they shouldn't be cause distraction to services. How can we find ways to navigate it? Is there any loopholes? We are also liaising with legal professionals, that is pro bono lawyers, to see what are the loopholes in the bill that can assist community to continue accessing services and ensure that it does not disrupt services and delay our hard gains. But one positive thing that I would say is that before the bill was passed, there has been a lot of security protocols. Some of you who were in Ghana for ICASA will attest to the fact that there were some security protocols that was developed. Global Fund implementers in country also have safety and security guidelines developed as part of implementation of Global Fund grant. There's a couple, and I'm sure that with all these informations and guidelines, community members will be able to know what to do and know what to do how to keep safe and ensure that we are able to access services. In generally, that has been the feelings in Ghana, but I'll throw more light as we go into further discussion. Thank you, and over, Solo.
Thank you very much, Watara. And now to just ask, this one, the next question I will pose it to Uganda, that is Jay. As Watara has asked, right? Post the anti-homosexuality bill and it becoming anti-homosexuality act, what are some of the opportunities you have seen during this process? Of course, in line with the present reality.
Thank you so much, Solomon, for that question. First of all, I'll speak about this whole topic in general. I don't want to be specific to the opportunities that we have got. And I will be driving it towards especially the trans community because it's what I mainly represent. First of all, as we discuss the future of HIV prevention, I want to begin with a simple observation. While innovation is important, we must also remember an important lesson that communities have learned over decades of responding to HIV. Technology alone does not save lives. People access prevention when they trust the system delivering it. People access prevention when they are treated with dignity. People access prevention when they feel safe, and people access prevention when they have choices. For many trans and gender diverse persons in Uganda, the greatest barrier to HIV prevention is often not the absence of technology. It is stigma, it is discrimination, it is violence, it is exclusion, it is fear. It is the reality that many people still encounter barriers when they attempt to access healthcare services. A person can know that PrEP exists. They can know where the clinic is located. They can know the benefit of HIV testing. But if they fear mockery, exposure, denial of services, or mistreatment, those prevention tools remain out of reach. This is why community-led responses remain just as important today as they were at the beginning of the HIV epidemic. Across the world, we are witnessing remarkable advances in HIV prevention, including long-acting PrEP, HIV self-testing, and other biomedical innovations. These tools are important and have enormous potential. However, people only access prevention when they trust the systems delivering it, when they feel safe, and when they are treated with dignity. For many trans and gender diverse persons in Uganda, the greatest barriers to HIV prevention are often stigma, discrimination, fear, exclusion, rather than the absence of technology itself. That is why community-led responses remain essential. At FEMA, we have learned that HIV prevention begins long before someone receives a test kit, a condom, or PrEP. It begins with communities have safe spaces, trust peer educators, mental health support, and opportunities to organize and advocate for themselves. We do not need to choose between biomedical innovation and community-led prevention. We need both. This brings me to the issue of meaningful engagement. For many years, communities fought for participation. Today, the challenges is influence. Meaningful engagement is not simply about having a seat at the table. It is about shaping what happens at the table. It is about influencing priorities, policies, budgets, and investments. There is a small background about the trans and gender diverse community in Uganda. This is one of the most marginalized within the LGBT community spectrum, facing severe stigma, discrimination, and lack of legal recognition. This has led to exclusion from essential services, including healthcare, legal protection, and social support. Despite involvement in global health initiatives, like those funded by the Global Fund, the trans community's representation has largely been limited, and interventions haven't been directly designed or implemented by the trans persons themselves. This has not translated into meaningful engagement, equitable resource allocation, often resulting in the trans community being grouped with the broader MSM population, which overlooks their distinct challenges. The KP constituency updates documents, which was outlining the work plan, resource allocation for key population under the Global Fund grant of GC7, as presented by the AIDS Support Organization, was not sufficiently addressing the needs of the trans community. Translate organizations were either excluded or mentioned in passing without clear mandates or resources for independent implementation. This limited trans community centric implementation and representation, perpetuating the marginalization of trans and gender diverse persons and undermining the effectiveness of the Global Fund's intervention and objective of the strategic plan to put people first. To address this,
Jay, you'll be brief.
Okay, let me be brief. To address this, we happen to get a CRG grant through GATE, and we have made sure that the TGD community in Uganda is never left out again in different HIV programmings and meaningful engagement, as it has always been. We have made sure the TGD community is well versed with the knowledge that is needed to engage meaningful, and made sure we are invited to be part of the whole processes. In Uganda, this work has become even more important in challenging environment following the passing of the Anti-Homosexuality Act. Yet one of the key lessons we have learned is that influence is still possible even in difficult political context. As the TGD community in Uganda, we have found that effective advocacy requires three things. First, evidence decision makers are more likely to listen when communities bring data alongside lived experiences. We invest in documenting barriers to HIV prevention, community experiences, and evidence on what works. Stories are powerful, but stories supported by evidence are even more powerful. Second, engaging early in the process by the time policies are written or budgeted, budgets finalized, many decisions have already been made. Communities must therefore engage at the stage where priorities are being set. During Uganda's Global Fund Grant Cycle 8 processes, FEMA and other community networks and orgs participated from the country dialogue stage through prioritization, discussion, technical working groups, and funding request development. This allowed us to influence conversations around community system. Lastly, coalition building in instructive environment. No single organization can achieve change alone. We work alongside key population networks, women's rights organizations, youth movements, researchers, and other civil society actors. Collective voices are often harder to ignore, more effective at navigating political power and influencing funding decisions. Thank you so much.
Thank you very much, Jay, into bringing the government perspective, the community engagement. And then now I would like us to go to Tanzania, so that at least you can tell us what are some of the successes are you seeing come this GC8 engagement with the key populations?
Yeah, thank you, Solo. Thank you, my chair. Yeah, actually, we, as Tanzanians, we advocated for enough space for key population to be at the writing space of the Global Fund Cycle 8, given that we had enough information on our fingertips through community-led monitoring that we conducted last year, KP-led CLOM, And we use that evidences to do advocacy on kind of services that we need, given there was a request on integration of services. And for sustainability, we had to factor in very crucial interventions that we as key population saw that they are very important for the Global Fund Cycle 8. So we managed to have a number of representatives, 6 key population into Global Fund Cycle 8, and they are still continuing because we are submitting in this the coming round or in June, this June. So we had a number of key population representatives and many inputs that we had through our community consultations were factored in through the writing and went through the grant making process. So we saw that we got that space and we are safe with our interventions. The only thing that we are left with is continue advocating for them and also the figuring out the implementation, how the implementation would be. So we have started advocacy on how key population-led organization will be factored in the implementation modality. Because up to now, we don't have the key population-led organization that is implementing community program under Global Fund. We have the PrEP-HIV-led, which succeeded to get the implementation piece on the GC7, but we are now figuring out to see how we could be supported as key population-led organizations to be in the implementation on the grassroots, so as to sustain the gains that were acquired in GC7. Because now the big challenge is that services are being integrated together. So it is very risky if we are not on the ground to implement, because some intervention might be lost because there are other implementers don't have an interest with the key population. For instance, maybe a partner can even use the peers who are not KP if you are not on the ground. So we are strongly advocating for key population-led organizations to take piece in the implementation so that we as community ourselves we implement and make sure that the sustainability goes on as if we are going to lose funds, but the community will continue to save each other. Thank you very much. I appreciate.
Thank you very much, Marinios, for even showing us the interventions. And of course, we are in this writing and we encourage countries to actually talk to each other. So our last panelist, Rita, I think you will come in and, just tell us, post stop work orders, how best do communities now actually put in their foot in the GC8 processes, and then we ensure we hold all the community interventions up to the end. And I will be giving you, Rita, 3 minutes so that we are able to close. And I'm so sorry, Rita.
Okay, Solo, that's okay. The presenters before me have said a lot of, have also really answered many of the questions. Before I just go on, I would like to, I'm hearing my next presentation, and I wanted to suggest maybe also if you could talk with TANPUD. I know we could also learn from each other. I know they're KP-led and they implemented GC7. So I wonder if there's also lessons that in country you can learn from each other about how they are pushing to be able to still implement GC8. But that one we can talk on the side. So Lo, your question is post-stop work order. How can key populations, did you say, put our foot on the ground and ensure what?
Ensure that interventions that, of course, are not funded, that have not been funded because of PEPFAR, actually get into the Global Fund Cycle 8. And now you have 2.5 minutes.
Right. So the first thing, as has been said by speakers before, is ensuring that we're working together as key populations. In previous grant cycles, we've seen typologies. Of course, you have to speak for your particular typology, but we've seen typologies representing us in spaces where let's say an MSM may not be able to speak for a person who injects drugs, or vice versa, or a trans person may not be able to speak for a sex worker. We need to make sure we all have the same information, and that whichever person goes to represent us in a space is able to advocate for all of us, especially now with limited funding. Something else that we have got to do, and particularly for people who use my experience with women who use drugs, people who use drugs in Kenya, is we have got to focus on system strengthening. Among the things that were not entirely cut off with the GC7 reprioritization was community system strengthening, that at least for Kenya. So in as much as we can, we need to make sure that our organizations are well equipped with systems that can allow us to not just seek funding, but be able to implement even when implementation arrangements come up. We need to be able to have a larger pool of advocates than we've had in the past, not just 4 or 5 from each typology who are able to advocate at a high level, because GC8 is highly technical. We need to also, we are actively looking for TA opportunities that will allow us to bring in consultants where consultants have are less now because of, again, the funding issue. And then, sorry, you asked something around ensuring that the interventions that had been left out have been put in. So this also comes down to collaboration. For example, we need communities at the center, but we also need implementers at the table, so that we have a very cost-effective analysis and a very accurate analysis of what's there and what our red lines are and what really must be put, what can go into PAR, what can go into the main writing, what can be merged, what can be, moved to a more innovative way. So really, the answer to that is speaking in one voice as key populations, that each typology has the information of the other typology, collaborating not just with the implementers, but with other CSOs, collaborating with all the other services that have been funded before under GC8. So collaborating with the legal services, collaborating with the GBV service providers, the SRH service providers, coming together to make sure that we have all the information necessary as we're going into the writing process, so that we can decide together on what our red lines are. And number 3 is system strengthening. I don't want to take too much time solo, but I hope I've answered your question.
Thank you very much, Rita. And indeed, I believe to all of us, in terms of the engagement and even how you have put, strengthening our systems, ensuring that the voices of the community are at the center, I have taken that home. And I hope all of us on the call actually now take that to our GC8 meeting rooms. And of course, if the chance for G2G comes up and a community member is actually nominated, please do use us and also do use the information that you have gathered from this webinar. And also, we need to have a space for continued conversation, because I know our panelists have a lot of experience in this area. And I will say that indeed, we need to do one real soon, like 1 hour of community engagement and discussion. So with that, I believe I will take it back to Tony, so that you can do the wrap up.
Thank you, Solomon, and for all you've said, and all the panelists. I think we are beyond time, and apologies for that. Allow me at this moment invite my senior Humphrey Ndondo from IMARAA to close for us. Humphrey, you got the floor.
Thanks, Ahmed, and thanks to everyone that's spoken before me. And in closing, really, we have the tools, we have the evidence, and we lack a coherent system to deliver prevention at scale. And I really do want to reflect on what we have shared with the South-to-South Learning Network. Some of the priorities for a robust HIV response speak to, 1, ensuring that there is country ownership in governance and policy, and that we are the prevention works when there's political will and government stewardship. Secondly, community leadership, advocacy, and communication is key. Thirdly, we need to prioritize. We need to prioritize and do some smart targeting So ensure that we know and we understand our epidemic. We have been talking about knowing and understanding our epidemic for years. Let's not run away from that language. Let's focus on all key populations in their diversity. Let's go where the new HIV infections are, and let us be data-driven. So we must invest where infections are actually happening. Fourthly, let's really interrogate the delivery approaches. Ensure that we are not losing differentiation with integration. We integrate everything, and we do not differentiate. In some places, we lose everything. So access matters as much as availability. Lastly, ensure that we have sustainable financing. Prevention fails when funding is suboptimal. I really want to take this opportunity to thank everyone that has spoken today and for all of you for joining. Ahmed, Clarice, Karel, Heather Marie, Anil, Maria, Solomon, Marinias, Rita, Watara, and Jay. Thank you so much for a brilliant afternoon and a very beautiful webinar. I'd like to turn this over again to Ahmed for closing off. Thank you.
Thank you, Humphrey. You are the one to close, but thank you so much. Thank you, every panelist. Thank you for participant. Thank you for being responsive to this call. This is not just a webinar as an abstract, but it is a commitment and a challenge for us to take action to ensure our packages for prevention is fast and secure. Thank you, and have a lovely evening and a lovely day wherever you are. Over. Thank you.